Good evening, everyone. I would like to welcome you to today's AHN Nephrology webinar. And today's is series number 103. It's a great honor to welcome you all. And the topic today is parathyroid disease, emphasis on secondary hyperparathyroidism. So this is a very important topic, especially for nephrologists and other people working in nephrology, because the prevalence of patients with secondary hyperparathyroidism is quite high, and it goes up to 30%, depends on the area where you are working from. Yeah, so therefore, it is a very important topic that we know exactly how to manage this topic, how to diagnose and how to manage. So this is very, very important topic. I would like to introduce our today's speaker, who is Dr. Richard Davis. Dr. Richard Davis is a program director of general surgery residence at the Kijabe Hospital in Kijabe, Kenya. He's a board certified general surgery, American Board of Surgery, and fellow of the College of Surgeons of East, Central, and Southern Africa. Dr. Richard Davis has worked and lived in full-time in Kijabe Hospital since 2007 and has an interest in head and neck and endocrine surgery. So it's a great honor to welcome you, Dr. Richard. We're so excited, waiting to hear from you. I have read your article, a recently published article regarding approach to parathyroid disease. So we are waiting, we are so excited, and you are warmly welcome. We'll hear from you. Welcome, Dr. Richards.
Thank you very much. I appreciate it. I hope I don't say too much that you already know, but it would be nice to sort of restate. My talk is called Parathyroid Disease, Emphasis on Secondary Hyperparathyroidism. That's Kijabe Hospital right there, an aerial view. And I have nothing to disclose. How can I make that? There we go. I have no financial images or pharmaceutical connections related to this talk. All the images in this presentation are from open source. That's one of my passions, is using things that are available to everybody and making material available to everybody. Endocrinesurgery.net.au gave me permission to use these things, and there is a written chapter version of this talk available. I'll make sure through Lloyd that you all have access to that. Here is a picture of the parathyroid glands. This is a little hard to see the glands, but actually it's sort of ironically appropriate because it is in real life hard to see the parathyroid glands. But this is a posterior view of the oropharynx and the hypopharynx and the cervical esophagus is this thing right here. Can you all see my arrow, by the way?
Yes.
So this is the esophagus seen from behind, and then the trachea is in front of it. And then these are the posterior aspects of the right and left thyroid glands. And then these little four things, they're about the size of a pencil eraser or maybe a little bigger than a grain of rice. These are the parathyroid glands in their normal location on the back of the thyroid. And you can see the blood supply to them comes from the inferior thyroid artery, and it comes up sort of medially and caudally to supply these blood vessels. So as surgeons, we're sort of coming in from lateral to medial here. And so we are able to preserve the blood vessels in that way, but that's their location. Here's what a parathyroid gland looks like. This is an adenoma, so it's a little bigger than normal size, but you can see its color compared to the fat adjacent to it. The fat is yellow and the parathyroid adenoma is a little bit more brown, but it's very easy to mistake the two, to take out a piece of fat thinking you're taking out a parathyroid, or to vice versa, take out a parathyroid thinking you're just taking out a piece of fat. Here is a diagram of a lateral view of the thyroid gland and the recurrent laryngeal nerve. And we draw a line through the recurrent laryngeal nerve. So the inferior parathyroid glands are going to be anterior to that line. The superior ones are going to be posterior to that line. It could be anywhere up here, even above where the nerve ends, but it's still posterior to a line through that plane. So that's what we're thinking as we go in looking for the parathyroid glands and try to find these little tiny, almost fat-colored, rice-sized, very important glands. A little bit about embryology. This is about the 7th week of development. So we're looking at, once again, the hypopharyngeal area. Here's the trachea just starting to form in the esophagus. The whole gastrointestinal tract is really just a straight tube at this point. So then we have the branchial pouches. The third branchial pouch is going to make the inferior parathyroid, and the fourth is going to make the superior. So you can see the third actually has much farther to go. When we talk about where you find the parathyroid gland, this becomes important because since it has to go farther in its migration to its normal position, it's more prone to ectopic location in the neck. So the inferior parathyroid glands are the ones that we have a hard time finding. Calcium metabolism, you all know much more about this than I do, but the normal serum calcium is 8.8 to 10.3 milligrams per deciliter. It's primarily a dietary source, and it's mainly stored in the bones. So it can be mobilized from the bones by basically dissolving bones to raise the calcium in the bloodstream. It's absorbed in the GI tract, and then in the serum, most of it is bound to albumin, but the part that actually matters is the part that's metabolically active. It's free, it's in ionized form, so it's free to participate in cellular signaling or other chemical reactions, or to complex with phosphate, as we see happens in secondary hyperparathyroidism. Here's a simple diagram of that. So the parathyroid glands release parathyroid hormone, which acts directly on the bone. It also acts directly on the kidney, and then through 1,25-dihydroxyvitamin D, it acts on the GI tract to increase the calcium in the bloodstream. And then there's a negative feedback from that calcium that decreases the work of the parathyroid glands as the calcium level goes up. Phosphate, the dreaded enemy in secondary hyperparathyroidism. It's a dietary source. Almost all foods have phosphate in it, and it complexes quite readily with calcium. So that's good. The bones are made of a complex of calcium and phosphate. So that's a good thing. It makes our bones strong. It's also a good thing we can use the tendency of phosphate to complex to decrease the level, at least in the GI tract, by using phosphate binders. So the phosphate readily binds to the binder and does not enter the bloodstream. But the bad aspect of this tendency of phosphate to bind is that at high levels, it will complex with calcium in the tissues of the body. So in the blood, and also out in the muscles and in the skin and all that. So we have to take the good and the bad of calcium's ability to complex with other elements, especially calcium. Parathyroid hormone's effect on phosphate in bones, it increases the phosphate. In the GI tract, it increases the phosphate. And in kidney, it promotes excretion, which decreases the serum phosphate. When I was a medical student, I thought that's not fair. The parathyroid hormone has different effects on phosphate depending on what organ it's working in. But I think the important thing to remember is that the kidney is where phosphate leaves the body, and it's parathyroid that tells it to do so. And then also I found out in preparing for this talk, phosphate actually is removed by dialysis. It's just not removed very readily. So you could theoretically remove more phosphate if the patient was willing to spend more time on dialysis. That's part of the problem with secondary hyperparathyroidism, is the patients aren't willing to sit on dialysis for longer than a certain amount of time, as we all know. Vitamin D metabolism, just a review here, the 7-dehydrocholesterol is transformed into vitamin D3 by UV radiation. Then in the liver, this is transformed into 25-hydroxyvitamin D called calcifediol. And then the key move in the kidneys, it's transformed into the only active form of vitamin D, which is 1,25-dihydroxyvitamin D, also known as calcitriol, and it's PTH activity on the kidney that causes this transformation. So there's no use in giving more regular vitamins like vitamin D3 to a person in kidney failure, because it can't make this last step to become calcitriol. So you have to give calcitriol to patients in renal failure or one of its analogs, and that plays in as well. I call this the childish diagram. It looks like it was drawn by a child, but it's actually quite useful for thinking about how secondary hyperparathyroidism works. So I'll just go through it. Calcium is green, phosphate is brown, PTH is blue, and vitamin D is black until it's transformed into the active form where it's purple. So PTH is released by the parathyroid glands. It stimulates the bones to release calcium and phosphate, and it stimulates the kidney to absorb calcium, to resorb calcium, I should say. It also stimulates the kidney to metabolize 25-hydroxyvitamin D into 1,25-dihydroxyvitamin D. which has the effect in the intestines of reabsorbing or of absorbing phosphate and calcium. And then right here in the kidney, this is where phosphate leaves the body at the command of PTH. So PTH tells the kidney to not reabsorb phosphate, and it enters the urine and leaves the body. So just as a teaser for the future, when we talk about secondary hyperparathyroidism, it all happens because the kidney doesn't do its job of removing phosphate, so or also of making 125 dihydroxyvitamin D. So that has a lot of downstream effects, which we will talk about in a second here. You have to consider other non-hyperparathyroid causes of hypercalcemia. I've listed them all here. I think the one you really have to think about is malignancy, including breast cancer and multiple myeloma. There's a lot of other ones listed here. We try to avoid doing parathyroid operations on people that have hypercalcemia for other reasons, of course, so we have to think of every one of these and look for them. Hypercalcemia, as we learned in medical school, it's stones, bones, abdominal moans, and psychiatric overtones. So the stones is calcium kidney stones. They can be in the parenchyma of the kidney or more painfully in the urinary tract, where they cause obstruction and swelling of the urinary tract and or dilation of the urinary tract, which causes pain. Bones, you can have bone pain as well as actual X-ray changes, and even tumors, osteitis fibrosa cystica, also known as Brown's tumors. Abdominal moans, people with hypercalcemia have a dull pain, they have constipation, they have gastric ulcers, they have reflux. And then the most interesting one to me is the psychiatric overtones. Extreme fatigue, anxiety, lack of concentration, memory loss, loss of motivation. Sometimes these people don't realize they have all these things, and then they have their parathyroid disease treated for some other reason, and they say, wow, I didn't even realize that I was depressed, that I had lack of motivation, and it was all because of the high calcium. So sometimes it's subclinical. Here's some picture of some stones, calcium oxalate and calcium phosphate stones. These have been broken up by lithotripsy, but still, this is just an example of what happens when the calcium is high. Here's some of the X-ray findings. So I think the ones in the hand are especially subtle, but you see here on this patient with hyperparathyroidism, there's a little sort of bite taken out of the cortical part of the bone. And then if you compare the cortical part of the bone, especially here versus normal over here, you can see it's somewhat lacy. It's thin. It's like it's got these little tiny holes of bone taken out of it by the fact that the bone was being reabsorbed. And then out here on the tufts of the distal phalanges, much, much thinner than this normal over here. The tufts of the distal phalanges is supposed to be sort of thick bone, so you can tap your finger against stuff, but here it's really thin bone. So I don't know if that makes sense. I don't know if I'm capable of picking this out on a plain X-ray, but it certainly can be seen if you know what to look for. Here's a osteitis fibrosa cystica or Brown's tumor. You can see the cortex is actually starting to buckle there already, and these do get pathologic fractures and present with pathologic fractures, and maybe even are diagnosed by biopsy of the tumor. But then you realize, hey, the whole problem was hypercalcemia and reabsorption of the bone all the time. As far as imaging the parathyroid glands, I think every surgeon should be very good at using the ultrasound, should be able to pull out the ultrasound and ultrasound any part of the body they want, especially the neck. And here's what a parathyroid adenoma looks like. It's sort of oval in shape. It's hypodense compared to the thyroid tissue that it's adjacent to. And if you put the Doppler on it, it lights up. It's very vascular, but this is typically what it looks like. It's nice to do this in the clinic and then to do it again in the operating theater right before the patient goes to sleep, and you have in your mind exactly where you're going to go. There's this thing called 4D CT scan, where the fourth dimension is actually time. So we look at how things in the neck behave as time passes after we give IV contrast. So here's a non-contrasted view, and this thing right here does not light up at all. You give IV contrast and you take the scan 30 seconds later, and here it is, very, very avid, almost as avid as an artery right there. And then 90 seconds later, it's starting to wash out. It's still a little bit brighter. You can also tell the difference between this and an artery because you scroll up and down and an artery keeps going, but this is just a nodule. So a nodule that lights up at 30 seconds and is still lighting up at 90 seconds, but much less so, is likely to be a parathyroid adenoma. This is useful for finding it in ectopic places like down in the mediastinum or around the heart or in between the esophagus and the trachea. And then the one that we tend to use a lot, but it does have its limitations, is the sestamibi scan. The real name of sestamebi is sestamethoxyisobutyl isonitrile. So that's why we say sestamebi instead. It was originally designed as a cardiac study, as a stress test, but they noticed that 2 hours later, the parathyroid glands lit up. So here we are at 15 minutes after injection of the radioisotope, and you can see the thyroid and the parathyroid. And you come back 2 hours later and the thyroid is still lit up. One thing that we have to remember about sestamebi scan is if you have multi-gland disease, only the biggest one will light up. So if you have primary hyperparathyroidism and you see one gland, that doesn't mean that it's only a single gland disease. There might be another one, but the dominant gland, the biggest gland, will take up most of the radioactive tracer. Different types of hyperparathyroidism. I'm going to talk about all four, but I will certainly focus on secondary. So primary hyperparathyroidism is an adenoma of one or more glands. And actually 15 to 20% of the time it's multiglandular. So you have to be careful. Like I said, the sestamebi will light up. You go in, take out that gland. You have not cured them of the disease 15 to 20% of the time, unless you've done something to make sure that the other glands were normal. Parathyroid carcinoma is a lot like primary hyperparathyroidism, except much more aggressive. The calcium's higher, the patients are sicker, and it's much harder to cure. Fortunately, it's extremely rare. I've never seen a case in my life. Secondary hyperparathyroidism is an effect of dialysis. I'm going to argue here that it's actually a normal effect of dialysis. And then tertiary hyperparathyroidism is when the glands have actually been doing what they do in secondary hyperparathyroidism for so long that they keep doing it, even if you withdraw the secondary hyperparathyroidism. I said here transplantation, but we certainly know that tertiary hyperparathyroidism can exist even without transplantation. It's just when those parathyroid glands have been getting stimulated for so long that they keep releasing PTH. And I'll talk about that in a minute here. First of all, primary hyperparathyroidism, it's a high serum calcium, usually not really, really high. So 10.5 to 12 milligrams per deciliter, and high parathyroid hormone. So greater than 70 picograms per milliliter. So you have to remember, if they have a high serum calcium, check the parathyroid hormone. It should be low if it's not hyperparathyroidism. It's one of those other things I showed a slide of. Sometimes it's subclinical. In fact, in industrialized countries, most of the cases are discovered on routine calcium analysis. That's part of what we call the basic metabolic panel. And you say, hey, this person's calcium is high. But we know that even if they're asymptomatic, treating the hyperparathyroidism is good for them and it increases their survival. And sometimes they realize that they were symptomatic after all. This is an adenoma of one or more of the parathyroid glands. It's not a malignancy. And then the treatment in a research-rich facility is imaging studies and then surgery. The imaging studies may allow you to do a smaller surgery. In a resource-poor setting, you just basically open up the neck, look at all four glands, and remove the hypertrophic gland or glands. Here's a picture of a minimally invasive surgery for a parathyroid adenoma. They knew where the parathyroid adenoma was. They were able to make an incision directly over it. Here's the adenoma right here. And this picture right here shows how close it is to the recurrent laryngeal nerve. So they have to be very careful of that as they're taking it out. Just recall that that's one of the danger things here. This is a nerve sensor. So you can actually touch that and the nerve makes a beep. It creates a circuit with the vocal cords through the endotracheal tube. So it's definitely a high resource thing. We don't have this at Kijabe. Here's another picture. This was a 4-gland exploration through a very small incision. They were able to look at all 4 parathyroid glands, and it's a good thing they did because they found 2 of them were diseased, not 1. This was one of the 15 to 20% of patients who have multi-gland hyperplasia. So this was the biggest one, but this one was also enlarged. If they had just taken out this one, the patient would not have been cured of hyperparathyroidism. Here's one more picture just to remind us all of how close these things can be to the recurrent laryngeal nerve. There's the recurrent laryngeal nerve right there, and that's the adenoma. If I was doing this surgery at this point, I would use a scalpel instead of a diathermy or something like that, and I would just peel this off the parathyroid gland with the scalpel. You have to be careful because if you rupture the parathyroid gland, they get this thing called parathyromatosis, in which all of these little pieces of the gland can implant somewhere, and the problem gets much worse and much harder to treat. So I would carefully peel this nerve off of the gland and then remove the gland. Here's a picture from Kijabe Hospital. This is a osteitis fibrosa cystica, a Brown's tumor of the mandible. This lady had a very high parathyroid, 1,733, and a very high calcium, almost double the normal limit. If I had seen that, I would have thought this person maybe has parathyroid cancer, because really high levels are more characteristic of parathyroid cancer. But she had this tumor in her mandible, and when they explored her neck, they found this one large gland. So this is the thyroid gland right here. This is the internal jugular vein. This is the carotid artery. And then this is the sternocleidomastoid muscle right here. And this one enlarged adenoma was right behind the thyroid gland, right where it ought to be. They took it out and her tumor started to regress. So they didn't have to do anything about the tumor. They didn't have to debulk it. They just treated the cause and the tumor goes back down to normal size. Parathyroid carcinoma, just to mention briefly, this is one gland, it's malignant. These patients present with a very high calcium and they present dehydrated. They have polyuria, they're confused, they're in shock. Before you try to reduce the calcium, you should resuscitate them using IV fluids because they are dehydrated. And then you can reduce the calcium using diuretics, bisphosphonates and calcitonin if you have it. Differential diagnosis, of course, is any other malignancy that presents with a hypercalcemic crisis. Breast cancer is prone to present this way. Multiple myeloma certainly is prone to present this way. So just consider other things that could be causing the calcium to be high without the parathyroid being high. Here's a photograph of parathyroid carcinoma. So hypercalcemia plus a mass in the neck equals parathyroid carcinoma, and the mass is often palpable and visible. Here is a photograph from one of my colleagues in the United States who did treat a parathyroid carcinoma. The treatment is surgical resection en bloc with adjacent tissues, followed by radiation and chemotherapy if you were not able to get it all out. And unless resection is complete, survival is very poor, even with radiation and chemotherapy. You can see here, this is the mass right here. This is the right lobe of the thyroid gland, which they had to remove because it was adherent to it. She tells me that the recurrent laryngeal nerve was also very close to this, but they were able to peel it off. If it had been invading the recurrent laryngeal nerve, it would have been appropriate to sacrifice the nerve, because otherwise, if you leave any of this tumor behind, the patient's simply not going to survive. Secondary hyperparathyroidism, an interesting way of thinking about this disease for me, and I'm aware I'm talking to nephrologists, but everyone with renal failure will have secondary hyperparathyroidism in a sense, because of it's actually a response to the fact that kidney's not working and not doing what it should do. The pathophysiology is complex. We'll talk about it in the next slide, but basically it's related to calcium mobilization and calcium phosphate deposition. So the manifestations are bone pain, proximal muscle weakness, atherosclerosis, and especially you have to watch out for coronary artery disease. That calcium can deposit and make calcific atherosclerosis in places where you don't want it, like the brain or the heart. Also poor wound healing, tendon rupture, pruritus, and then these skin lesions called calciphylaxis. Here's our childish diagram again, but it's helpful if you think, if the kidney stopped doing what it's supposed to do, that is eliminating phosphate and making 1,25-dihydroxyvitamin D, what would happen? Well, you'd have the PTH is what's driving the kidney to release phosphorus. So in response to phosphorus level rising, PTH goes up. Vitamin D deficiency because of lack of renal function also drives PTH up, because PTH is telling the kidney to make vitamin D. And then last of all, but perhaps worst of all, as the phosphate level rises in the bloodstream, it complexes with calcium and deposits in tissues. And this actually drives the calcium level down, which also makes PTH come out. So PTH is going up as it should in response to all these things. And that's actually a pathologic response, because this whole cycle here has been broken. Calcium turnover is increased, and serum calcium in the secondary hyperparathyroidism patients I've seen, it's normal or sometimes even low. The PTH, on the other hand, is very high. I've seen patients above the thousands, and the normal again is 10 to 65. Let's see. Here's a picture of calciphylaxis. So this is basically the calcium phosphate has deposited in the skin. It's damaged the blood vessels, and they have these characteristic black lesions. Actually, they can get sort of necrotic black eschar in the middle of the lesion. These are very painful, and it's actually quite a poor prognosis. If the patient has calciphylaxis, it means that their hyperparathyroidism is out of control, and they're probably not going to do well in the long term, as I'm sure you guys, as nephrologists, all know. Treatment of secondary hyperparathyroidism, it's useful to look at this diagram again to think of the treatment. You can dialyze phosphate out, but again, it takes long sessions on the dialysis machine, and the patients aren't willing to sit there for that long, is what I've heard. Phosphate binders in the GI tract will prevent you from absorbing too much phosphorus. You also modify their diet. You tell them not to eat too much processed foods. Try to focus on foods that are lower in phosphates. And then you can give calcitriol. You can't give vitamin D, as I said, it won't get converted, but you can give this calcitriol, 125 dihydroxyvitamin D, or its analogs, and that will have the effect of decreasing the feedback loop on PTH. And then if you have this cinecalcet, it's a calcium mimetic. In other words, it imitates calcium. So it goes to these parathyroid hormones and activates them and sort of fools the parathyroid into thinking that there's enough calcium and they don't have to release PTH. And it actually works really well. As we were saying in the discussion beforehand, when cinecalcet was first released in 2006, the amount of parathyroid surgery happening, at least in places where it was released, dropped a lot. So I imagine you guys either get cinecalcet from India, as you've said, or you just do all these other things. But the success of your treatment, your medical treatment of secondary hyperparathyroidism, is measured by PTH levels. So actually, PTH levels is one indication that your treatment is failing and that it's time to think about surgery. Tertiary hyperparathyroidism, I'll just say briefly, after years of stimulation, the parathyroid glands have become independent. The textbooks say this happens after renal transplantation, but is not necessarily true. Even if you don't do renal transplantation, those parathyroid glands can become independent just after years and years of secondary hyperparathyroidism. But the proof is, if you cure hyperphosphatemia and the vitamin D deficiency and the complexing of calcium and phosphorus or phosphate into calcium phosphate deposition, the parathyroid glands don't stop making PTH. They continue to hypersecrete, and now the calcium levels go high again because the other things that make it deposit in the skin aren't happening anymore. But the parathyroid glands are still releasing PTH and raising the calcium levels high. Indication for surgery in secondary hyperparathyroidism, it's not quite so cut and dry. PTH greater than 800 with symptoms or PTH greater than 1,000 all the time. We don't really look at it that way, like simplistically like that. We would individualize treatment because actually these patients are all, as you know, very sick. They're very poor surgical risks. They have renal failure. They have poor wound healing. They're prone to bleed. They're prone to get complications during surgery, including myocardial infarction and stroke. So the best patient for a parathyroidectomy is a younger patient and one who does have severe symptoms. And I've had a few patients who tell me, I didn't realize how symptomatic I was until after the surgery. If you do in-depth questioning, you'll find a lot of these patients do have symptoms of their hyperparathyroidism. So really, it's an individualized choice. It's not something that the surgeon says, yes, it's more sort of like we discuss and decide what would be best. And then we even discuss with the patient, the most important decision maker, are they willing to accept the significant risks of surgery for the chance to feel better, or can they keep going with the way things are? Surgery of secondary hyperparathyroidism is multidisciplinary. Anesthesia is very involved. They are going to decide how much preoperative evaluation the patient needs for coronary artery disease. In industrialized settings, all of these patients get stress tests and echocardiograms and things like that. They're going to be doing the intraoperative management of a surgery on a patient under general anesthesia with renal failure. And these patients get hypocalcemia during the surgery, so they have to start treating the hypocalcemia immediately. The surgeons, our job is to locate all four glands, avoid postoperative hemorrhage, avoid damage to the recurrent laryngeal nerve, and all those other things. And then nephrology, their work begins after the surgery. They're going to dialyze the patient. They're going to dialyze with a calcium-rich bath. They're going to replace calcium and vitamin D. And as you know, the bones have been sort of whipped like a tired horse into giving up calcium for so long that once that stimulus is taken away, they get hungry bone syndrome. They'll take as much calcium as you give them. And the patient will get postoperative hypocalcemia, even as you're pouring calcium into them. This can be life-threatening if it gets too low. So what kind of surgery are we doing for secondary and tertiary hyperparathyroidism? Well, we can't just take out all the parathyroids. You need parathyroid tissue. So we're doing debulking. It's like a lot of endocrine surgery. We're trying to leave just the right amount of endocrine tissue behind. So we would do a 4-gland exploration, look at all 4 of the glands, and then resect 3.5 of the glands. What do you do with the remaining 1/2 of a gland? There's really 2 options. One, leave it where it is. So if you leave it in the neck, it's easier to do, and it works better for the patient immediately because you're actually preserving its native blood supply. So you just kind of take one of the glands and cut about 2/3 of it off, and you leave that parathyroid tissue. It's still stunned. It still doesn't like to be disturbed, and it still doesn't work right away, but there's less time that it's stunned, and it starts working faster. So you actually have less problem with postoperative hypocalcemia. It actually resolves faster. The disadvantage is that if this disease recurs, if that one piece of parathyroid tissue grows back and becomes too much function once again, it's very dangerous to re-explore in the neck, especially if you were near the recurrent laryngeal nerve. You can have bleeding. It's harder to operate a second time with all the scar tissue in there. So if you believe it's likely that you will have to re-explore this patient, especially if you don't have cinecalcet, I would say you plan for a reoperation. You take the last 1/2 of the gland out of the neck and you reimplant it in the forearm. So it's a safe, simple reoperation. You can do it under local anesthesia. You just go find the gland and debulk it some more. The trouble is it may take a while to start working. It may even take up to a month if you replant the gland. It's really going to be angry. It's really going to take a while till it's working again. And so you need to give them a lot more calcium during that postoperative period. Here's a picture of a 4-gland neck exploration. You can see they've got the neck wide open. They have to mobilize both lobes of the thyroid, and then they have to find those, all the calcium or all of the parathyroid glands. They have to take them out without rupturing them and maybe leave some behind. So that's one picture there. Here is a picture of this. This is a little bit hard to see, but this is the right thyroid lobe here, and they've retracted it towards the midline. And here are 2 large parathyroid glands. This is about the size they are. They're like the size of your thumbnail. And so they are within the capsule of the thyroid. And here is the left thyroid lobe retracted towards the midline. Here's 2 more parathyroid glands. So if you're deciding to leave 1/2 of one in situ, you would choose the one that has the best blood supply and is farthest from the recurrent laryngeal nerve, and then just chop off about 2/3 of it and leave them with maybe about this much parathyroid tissue functioning. Here are the 3.5 glands on the back table having been removed. Looks like they left some of this behind. But that's the goal, is to go in and get this view, see all 4 glands. After you have all 4 glands in view, then you decide which one is the most feasible to leave behind. Just a brief word on what do you do if you can't find 4 glands. Remember your embryology and your anatomy. You're looking for the inferior gland anterior to the recurrent laryngeal nerve and inferior to this structure called the tubercle Zuckerkandel. You're looking for the superior parathyroid gland posterior to the recurrent laryngeal nerve and above the thyroid in this whole space here. So, and then once again, because of the embryology, the inferior parathyroid gland has farther to migrate, and so it's more prone to be in an ectopic location. Here's a little diagram of some of those locations, just in case any surgeons have joined us later. This might be useful to you. Up behind the larynx, in the groove between the trachea and the esophagus, and then in the carotid sheath itself. So open up the carotid sheath and look inside. Within the thyroid gland, strangely enough, and then the inferior parathyroid glands are the ones that can be just about anywhere down here. Within the thymus gland, inside the chest, or down by under the aortic arch, next to the superior vena cava, even down by the atria of the heart. These ones you're not going to find during surgical exploration. This is the kind where you'll say, I only found 3 glands. Let's stop the operation and do a 4D CT scan and see if we can see any more of these. But a common maneuver, if you haven't found the inferior parathyroid gland, is to either remove the thyroid lobe on the side you haven't found it, or to go down to the neck and take out the thymus gland, to do a cervical thymectomy, because it could be in either one of those places. Hypoparathyroidism is temporary after this surgery. As I said, hungry bone syndrome. Patients require large doses of calcium and vitamin D. They'll be on an IV drip post-op for several days while you increase the oral dose until you can get them off the IV drip. Some feel that you can decrease this by dosing calcium and dihydroxy vitamin D for about a week before surgery. Some nephrologists don't agree with that. Why would you give calcium to someone who's already got too much calcium turnover in their body? But it does work. If you do a forearm replantation, it may be a month before you get this patient stabilized. And then permanent hypoparathyroidism, the dreaded complication of any thyroid or parathyroid surgery, more often seen as a complication of thyroid surgery. It's damage to parathyroid glands that is not recoverable. The thyroid gland is just destroyed. In parathyroid surgery, in this case, maybe you removed too much parathyroid tissue, or the blood supply of what you left behind was damaged during your dissection, or it failed to replant in the arm. So this is the problem with endocrine surgery, is you're trying to leave just the right amount of functional endocrine tissue behind. And if you get it wrong, they will be hypoparathyroid afterwards, and they'll have to take calcium supplementation for the rest of their lives. Clinical manifestations of hypocalcemia, we all know this. Chvostek's sign is a twitching of the lip, the lower lip, especially when you tap on the cheek right in front of the ear. It's irritability of the facial nerve, which causes the lip to sort of twitch. Trousseau's sign is when you inflate a blood pressure cuff or a tourniquet on the arm, and after about a minute, they start to get this thing called carpal spasm. I've actually seen it once in a post-op thyroid patient that we couldn't get an IV on. We had a tourniquet around their arm trying to get an IV. And after 2 minutes, the wrist spasmed, and it dawned on me, I know what's wrong with this patient. It's hypocalcemia. Laryngospasm is a consequence of extremely low calcium, and that can be life-threatening, of course. So in conclusion, parathyroid hormone has effects on calcium, phosphorus, and vitamin D. Primary hyperparathyroidism is simply just too much parathyroid hormone from an adenomatous gland, or more than one adenomatous gland. Secondary hyperparathyroidism is too much turnover of calcium. It is a natural consequence of renal failure. When the kidney doesn't do what it's supposed to do to phosphate and to vitamin D, it has the effect of increasing calcium turnover and also deposition of calcium phosphate. Tertiary hyperparathyroidism is the same thing, but with autonomous parathyroid glands, can't be medically managed. It happens after prolonged secondary hyperparathyroidism. And surgery plays a large role in treatment of all forms of hyperparathyroidism. This is especially when medical management of secondary hyperparathyroidism has failed. And the goal, as in all endocrine surgery, is to leave behind an appropriate amount of parathyroid tissue, not too little, not too much, and possibly in a place where it can be surgically accessed later on if you need to go back. So that's my talk. Thank you very much. I will stop sharing screen.
All right, Dr. Davis, that was excellent presentation. Before I hand it to Dr. Marin, I would like to ask you one question or comment for sure. So,
please.
Yeah, PTH in Kenya, I don't know how cheap it is. Here in Tanzania, it's really very expensive, and patients can't really afford to do the PTH tests. And number two is, have you ever experienced or seen somebody doing like percutaneous abrasion of the parathyroid glands using ultrasound guided? We have tried it in Tanzania, but we couldn't see the lower, the lower two parathyroid glands. We were able to see the proximal one, but the distal one couldn't be seen clearly. And we tried once, then we couldn't finish because we didn't see. So I would like to see your view on that. Yeah.
So I have not ever heard of percutaneous ablation of the parathyroid glands. My reaction to it is it would be very difficult to leave the right amount of tissue behind. I think percutaneous ablation is kind of an all or nothing phenomenon. You stick a needle into a gland and you destroy it. Is it through heat, or is it through injection of alcohol, or
it was an injection of alcohol, and it took like 94% alcohol, and then injected.
So how do you make sure? Yeah, how do you make sure there's any functioning parathyroid gland left? Because part of the goal of the surgery, as I said, was to leave just the right amount of functioning gland behind. I don't see how you do that if you were injecting alcohol into the gland. That's my reaction to that idea.
The PTH levels, monitor the PTH levels over time. There are papers on this, and so we actually tried this because the hands were tied. Patient could not afford. But
even for us, we couldn't.
Actually, again, I did it. Yeah, go ahead again.
Well, you've got me. I've never heard of that. I never heard of that before. I can't say anything. It's an interesting idea. I've never heard of it.
Yeah, but we couldn't, sclerose all the glands only to, but we couldn't visualize the distal ones.
Interesting.
So yeah. But as Dr. Lloyd said, you keep on measuring the PTH level.
Okay.
Yeah.
So you don't do it all at once. You sclerose the glands, and then you see what the PTH is, and then you sclerose some more.
Exactly.
That's an interesting idea. No, I've never heard of that.
Yeah.
All right. And then about the PTH level, I have to plead ignorance on that one as well. My experience with this has been in America. I mean, I know we do check the PTH levels in Kenya, and in our lab, it's a send out. I can't comment on how much it costs or how accessible it is to patients. I think that's one issue we'll have to work out if we do start doing this surgery commonly at Kijabe Hospital.
All right. Thank you very much, Dr. Davis. Marin, you want to take?
Sorry, so I was saying Cinacalcet is available, but it's usually very expensive, about $40 a month, which most of our patients cannot afford. And therefore, this surgery comes as a blessing. I think we'll just look at the first question. Injury to the recurrent laryngeal nerve, leading to vocal paralysis. When you depicted that diagram, the recurrent laryngeal nerve is so close by. And considering we don't have that type of equipment here in Kenya, what has your experience been? Is this a very common complication post-surgery?
So I think the reason it's not a common complication is because you just take your time with these patients. I mean, these patients are very fragile. The tissues are very fragile. You don't want any bleeding. So this is a surgery we do very, very slowly and meticulously with very keen attention to hemostasis. And so I think the idea is that we know at all times where the recurrent laryngeal nerve is. It happens at about 1/3 of 1% in thyroid surgery, and you're actually much closer to the place where the nerve enters the larynx when you're removing an entire thyroid gland. And this one, it's actually probably easier to avoid injuring the recurrent laryngeal nerve because it's not, despite the pictures I showed, it's not as closely associated with the parathyroid gland as it is with the thyroid itself. And African surgeons have a lot of experience operating on thyroid glands, so I think they could take to this pretty easily as far as preserving the recurrent laryngeal nerve.
Okay, that's wonderful. And then Dr. Davis, considering again a lot of our patients are unable to afford a lot of our treatments, just as a guide, what type of cost are we looking at for this surgery, considering I guess it would be 1 or 2 days post-operative in the hospital as well? So what type of are we looking at?
Yeah, I expect the patients I've seen in the past have been at least a week in the hospital, sometimes more, just because of the calcium issue and the need to get the calcium level exactly right before you send them home, where you're not checking their calcium anymore. I don't really know the cost. I would guess it would probably be between 300 and 500,000 shillings, probably all told, including time in the ICU and all of the assays and all of the medical interventions to keep the calcium in the therapeutic level. NHIF will pay for this surgery though, so I believe we can at least have NHIF pay for it, or pay for some of it.
Oh, that's wonderful.
Right, that's great to know. I mean, that's very reassuring to our patients. And then probably we had one question that was post-operatively, now again, the frequency of rechecking PTH and calcium. How frequently should we expect to be doing that, and for what duration post-op should that be continued? In your experience, what do you feel is appropriate?
Yeah. Again, my experience was in an industrialized location only. I have not done this operation in Kenya before, and they were checking the calcium every 6 hours for the first 3 days. They had them on a continuous infusion of calcium. They had high calcium in the dialysate, and then they were giving the oral calcium and trying to taper the IV calcium as they gave the oral calcium. And that process took, like around day 3, they would be getting pretty low or off the calcium drip. but it was about that long. At least the first 2 or 3 days, they were in industrialized settings, checking that calcium every 6 hours. That might be a little excessive for our setting, but I think we're going to have to come up with something that still preserves patient safety, and that just does show you how much the calcium levels fluctuate after this surgery.
Absolutely, and I think even Dr. Lloyd would probably agree on that, that we would have to individualize that. And have you seen, I mean, post-operative long-term, any complications, surgical, that you would like to highlight maybe for our patients in long-term?
So I mean, I think one complication I didn't mention, which was post-operative neck hematoma. That's not a long-term complication, but it's pretty rare in thyroid surgery. It seems a lot more common in parathyroid surgery. I think it's just because these patients are so fragile. I can't say that I have enough long-term experience to say at what rate these patients require reoperation. And also, again, my experience is in a place with cinacalcet. I would think without cinacalcet, reoperation for recurrent secondary hyperparathyroidism would be more of an issue, and probably the most feared long-term complication is just having to go back in again and debulk the parathyroid glands again.
The difference between total versus subtotal parathyroidectomy and implantation, of course, total with implantation, without implantation, and subtotal. When will you do a subtotal parathyroidectomy?
I think for me, I would do a subtotal at all times. I would always want to leave some functioning parathyroid tissue behind. I think it's disabling to not have a working parathyroid gland. So like I said, my goal is to leave just the right amount of functioning endocrine tissue behind, whether that's in the arm, because I expect I'll have to debulk again, or whether that's in situ in the neck, where medical management is optimized and probably won't have to go back in.
And now we have a patient, two patients who actually went to India and came back. And this was about a year ago. Another went and had a total parathyroidectomy with an implant in the forearm.
Yes.
And the PTH, when she went in for the surgery, was about 2,500 micrograms per.
Okay.
And came back post-op. It was really low, but now it's around 600. I mean, and she's got a gland implanted in the forearm. Yeah. So, as per guideline, the 600 is okay. I don't know whether we really need to, or should we really go intervene now? She is asymptomatic right now. So this is the situation. So whether she should go in again, and what do you do in the arm now? Would you again explore the arm and take it out, or again divide it? Or if it's an adenoma, growing adenoma, what would you do?
Well, yeah, I mean, basically the parathyroid tissue is just doing what parathyroid tissue does in secondary hyperparathyroidism, which is responding to the low to the high phosphate and the low vitamin D, and just responding to that by growing more. So it's a relatively simple operation in the forearm. I've never done it before, but it's you can do it under local anesthesia, and you just explore and again debulk the tissue, leave some functioning tissue behind. Probably doesn't need it right now, this particular patient, but I think that the benefit of leaving it in the forearm is that it's a much less difficult, much less dangerous operation. So you can do it a little more, I don't know if lightly is the right word, but like when the patient needs it, you can do it without having to worry about recurrent laryngeal nerve injury, hematoma, things like that. So it's really, it's a pretty good situation for her. When she needs it, it'll be somewhat easy to do, just debulk that tissue one more time.
Again, the one of the major problems I saw the immediate post-op, which we discussed actually, was the hungry bone. That the calcium level dipped so badly.
Yes. Yeah.
Very
well,
badly.
And she didn't have any functioning parathyroid tissue probably for a long time, because that, as I said, that takes longer for that tissue to replant and get its own blood supply and start working again if you put it in the arm. So it's a longer process than if you leave it in the neck at first, although, like we said, it's worth it in the end because it's easier to deal with the second time.
I think we hope that we could actually, we've been searching, there are a lot of patients who need this, and you see when cinacalcet is very expensive, and when your PTH is 600 to 800, I think, and some of them are symptomatic with even higher PTH levels. I saw one of them, maybe about 6 months ago with a level of about 1,600, and absolutely no money for the cinecalcet. So this is something that is a problem. Yeah, NHIF pays for it. It's really good. I wonder, Gina, if Tanzania NHIF pays for surgery.
No, it doesn't. NHIF doesn't pay for it.
Okay.
But they're quite available. I was trying to ask my colleagues. They are available in the market in Tanzania for now, but they're very expensive. And as you clearly pointed out, Dr. Lloyd, patients can't afford persistently for 3 or 4 more weeks taking cinecalcet. It becomes difficult.
So it's lovely. I mean, it's really great if you all can start it there in Kijabe, and you'll have a great team. I think we really look forward to sending people out there. Here. Yeah, and even in from across Kenya, there are a lot of them actually who do have high PTH levels. I have seen a couple from there as well, from Chagoria side. I think they will benefit from the NHIF as well. That's a really good thing.
Well, maybe we should write a protocol for these and sort of protocolize the treatment, so we're not figuring it out as we go.
Yeah.
I think we'll move. I think on that note, Dr. Gino, we have a hand raised from Dr. Joseph Tarindwa. Let me allow him to ask his question.
All right, thank you.
Thanks, Dr. Davis. I'm from Rwanda. Thanks for an excellent presentation.
Thank you.
But now you kept on referring to parathyroid levels, but laboratories actually laboratories refer different.
I think you're breaking up, Joseph. But you're asking about reference levels. I'm sorry. Could you repeat your question?
I think he's referring to the PTH fragments that are measured in the labs. That's his question.
The
We're
PTH,
referring to the whole PTH or the active metabolites.
Yeah, I think for me, I only have experience with the intact PTH, the whole PTH. Yes.
Yeah, the whole molecule or the active metabolites.
I believe it's the whole molecule. I actually don't know the answer to that one.
I think Lancet measures the intact molecule, the whole molecule.
Okay, yeah, that's something we'll have to look into. Although I think you know more about that than I do if you're actively measuring PTH on people all the time to assess your treatment.
Yeah, the reason I asked it because when I was working in South Africa, in a renal unit, I think the Lancet laboratory actually, at some stage they are giving us the active. The active metabolite levels, or some they would give us the reference values, and at some other stage they would give us the whole molecule, so that even when you read, even in the literature, actually they keep on reference to active metabolites and so it is good to know. What the laboratory is telling you about. I think it is just another question I wanted to raise. If you get a lab result, it would be good to know what they're referring to.
Yeah.
And thank you, Dr. Tarindwa, for that question. I think in terms of Lancet, like over here, PTH is measured. We don't do the metabolites, but obviously that would vary across different labs. If we have any other further hand, there was one more, but I think it's gone down. Dr. Paris, if you still have a question. We're really grateful for enlightening us about this and letting us know that this surgery is covered by the NHIF. I think it's going to be very beneficial to our patients. And so for that, we're incredibly grateful to you. Not only that, for also spending this over an hour with us and educating us on this procedure, the process, and reminding us about its importance in patients, since obviously cinecalcet is a challenge for most of our patients. So we're incredibly grateful to you, Dr. Davis. And I would like to thank you for your time. And I hope that we'll have many other such fireside chats. Hopefully, once more of our surgeons are also trained in this procedure. And on behalf of the whole Africa Healthcare Network, I would really like to thank you for giving us your time today.
Thank you very much. It was a pleasure to be with you guys.
Thank you, Dr. Davis. Extremely grateful. And I think that's a great start. We should, I think you do have a lot of patients, I'm sure. And the fact that it covers will be a really great boon, as Mary said. Thank you so much for your time as well.
Thank you.
Thank you. I think as we said, the protocol and I think it's gone into some discussions with the patients and some sort of a group that could be formed, so these patients will benefit as well.
Thank you, Doctor. Thank you, Dr. Davis. It was an incredible and excellent talk.